Hello, everyone, and welcome to today's webinar titled The Importance of Timing, Managing COVID-19 with a Live Q&A. This webinar is part of the 2022 Microbiology Virtual Week, and I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational seminar is presented by LabRoots. So let's get started. Before we begin, I want to remind everyone that this event is interactive, and we encourage you to first participate by communicating with other attendees using our new live chat feature during the presentation. You can find that live chat located at the right of your screen. You can also participate by submitting as many questions as you want during the presentation. So to do so, simply type them into the Ask a Question box and click Send. Now, if you have any trouble seeing or hearing this presentation, just simply click on the Help Desk button located at the bottom of your screen within the navigation bar or from the lobby. And finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on that continuing education credits link located in the abstract window below the presentation window and follow the process to obtain those credits. I now present today's speaker, Dr. Daniel Griffin. Dr. Griffin is the Chief of the Division of Infectious Disease at Optum Tri-State and the Clinical Instructor of Medicine at Columbia University College of Physicians and Surgeons in the Department of Medicine in the Division of Infectious Diseases. Dr. Griffin, welcome. You may now begin your presentation, sir.
All right. Thank you so much. And welcome, everybody. I just want to reinforce that I'm going to be talking for a bit too long, perhaps. But the biggest thing I want people to be doing is thinking of those questions. I'm going to be focused on the importance of timing in managing of COVID-19. We have three main learning objectives. One, I would like people to walk away from this 1 hour of their life understanding the viral kinetics and the impact on testing for patients with COVID-19. This has evolved over time, so we're going to be talking quite a bit about that. That's going to lead directly into what are our available testing options. I'm hoping people are going to really have a good, solid understanding of the available testing options. If we can't make the diagnosis, how do we move on to number three, which is I want everyone to be able to apply what right time, recognize the right time for the right therapeutic in an individual patient. And this has evolved over time. We've come to really understand that the right drug at the wrong time ceases to be the right drug. So we'll be spending some time on that. So right into the abstract, and this is going to be the most verbiage you see on the screen for the next hour. So critical in control of this pandemic is the ability to rapidly identify infectious individuals prior to their ability to infect others, right? If we can do something as we're heading into this fall and this winter to keep folks from spreading it to others, that definitely is challenging. With the introduction of better testing capacity and an understanding of how to use these tests, the current challenge is making sure patients have access to the correct therapies at the right time. A simplified framework. So there has been a framework, but now we have a simplified framework for identifying the phases for different therapies, and application of available therapeutics can greatly improve the chances of a positive outcome. So what are these stages? Now, there are two preclinical periods, and we'll be talking about what we can do in the pre-exposure period. This is before you've been exposed to someone. We're going to be talking about you've been exposed and potentially now you're incubating. The virus is starting to replicate, but not at the point where you test positive, not at the point where you have symptoms. And then we'll move into the four clinical phases. The early viral upper respiratory non-hypoxic phase. This is maybe referred to as the mild COVID, not necessarily meaning it's going to remain mild. Then we have the next phase we'll be talking about, the early inflammatory lower respiratory hypoxic phase, right? This is that week 2. This is what caused our hospitals to get flooded with patients requiring respiratory support. That's where we were seeing a lot of patients really heading in the wrong direction. But when we're going to talk also about the fact that this is not a 1-week illness, it's not a 2-week illness. For a lot of individuals, there is a secondary symptomatic phase. We'll talk about, is this the rebound that people are talking about? Is this a second rebound? We're also going to spend a little time on the tail phase. What do we know about it? What can we do about it? And everything I'm going to be talking about is evidence-based. It's in line with the following guidelines, the guidelines of the ID Society of America, the NIH COVID treatment guidelines. And what I do want to point out is that there's a certain urgency. The amount of enthusiasm you'll hear in the next hour is not just because I had a cup of coffee with an espresso shot, but the fact that here we are in September of 2022, we are still seeing about 500 deaths a day in the United States from COVID-19. And I am going to put forward that the majority of those deaths are preventable. And if we really know the science, if we know the evidence, if we can have those conversations with our patients, we ourselves might eventually be patients. So if we can also know from that end what to do, I would like to see that number really go down. So let's go through. So we will start with the pre-exposure period, right? We've been talking about masks now for 2 years. Ideally, we would have been talking about masks for a little bit longer than 2 years. But we have moved from everyone wearing masks to widespread mask mandates to more vulnerable individuals using what we refer to as one-way masking. So the risk of a bad outcome with COVID is very different for very different individuals. The young, healthy individual is at relatively low risk of ending up in the hospital, relatively low risk of death. There still is the long COVID risk. But for elderly individuals, majority of deaths are now occurring in people over the age of 80. These individuals are now going into circumstances where they want to keep themselves safe. And so we'll be talking a little bit about what those different mask options are. Physical distancing. This continues to be something that we need to talk to our patients about. We've really understood that this is a respiratory disease. So as a respiratory disease, there is a benefit. There is a risk reduction to getting 3 feet away, getting 6 feet away. But that really has the biggest impact when we are outdoors. Outdoors is safer versus indoors. There's certainly a degree of spread that occurs because of poor ventilation. A lot of spread occurs in that suburban home, in that poorly ventilated office. So outdoors is certainly safer than indoors. Again, something to think about in our higher risk individuals who are being invited to these large gatherings. Moving us into limiting the size of gatherings is still is critical. Small group together is quite a bit different than a large group. The more people there, the more chance that you're going to introduce a person into that crowd who is infectious to others. Particularly if that's indoors, we can really see significant secondary spread. Now, washing hands and hygiene, I like to say, can help. I don't want people to stop washing their hands, but this is really not a contact transmitted pathogen. This is really a respiratory transmission. Frequent testing, right? This is going to have to be judged. Does that young, low risk person have to get tested, 3 times a week, like some of our businesses were doing? Should testing be done when a person is going to potentially be around someone who's high risk? So frequent testing, but really, I like to say intelligent use of those tests. We have a lot of access to tests, but let's use them intelligently. Symptom checking, this helps a little, but as we've run into, maybe less so now, individuals can be infectious to others before the onset of symptoms. Even people can remain asymptomatic during their entire infection and still spread it to others. So symptom checking helps a little, but this is not like influenza. This is not like some of our other infectious agents. And vaccines, we're going to be spending a bunch of time on vaccines. I'm hoping there's going to be a bunch of questions on these bivalent boosters that just got approved that people are now scheduling. Where do they fit in? What are we hoping to accomplish? And I am going to really hammer the distinction that vaccines prevent severe disease. They do not prevent all infections. And hopefully that's really clear to everyone now, but we'll talk about what that means. All right. So masks. This is, as I mentioned, we have moved into the one-way masking period. There are different types of masks, and these different masks have different abilities to protect us, and they also have different abilities to protect individuals in large gatherings. Really, the respirators, the N95s, the KN95s, these are really those masks that we're recommending for those highest risk individuals who want to get out there. They want to go to that big indoor event because it's important to them. Maybe it's a graduation, maybe it's a birthday party, maybe it's some celebration, maybe it's upcoming holidays. And this is where we have that conversation to provide them with the most personal protection, the highest level of personal protection, the quality of masks. I mean, it may not match your evening gown. It may not match your bow tie. I have a lot of wonderful cloth masks, but for that highest level of protection, the type of mask does matter. Pre-exposure, in most situations now, the mRNA vaccines are preferred. We have the Pfizer BioNTech, we have the Moderna vaccines. These are preferred over J&J. For completeness, I should throw in the mix that we now have Novavax. We now have the protein subunit vaccine. Now, what is the goal of our vaccines, and what are we seeing, and what sort of discussion do we have to have with our patients? I think the biggest thing here is we do not want false expectations. Now that we're hearing about polio again, that's a good disease to use as an example. The injectable polio vaccine, protection against infection, 0. The protection against infection that we get with our vaccines, I like it to sunblock. Okay, even if we say a 90% protection, if you put 90% protection on your skin and then you spend the entire day laying out at the equator, you're still going to get a sunburn. So these vaccines are going to reduce our risks of infection, probably temporary, probably during that period of time when those antibodies are very high. But as the antibodies go down, individuals are at increasing risk of getting infected. But what we've seen with a significant degree of durability is protection against death, protection against ending up in the hospital, protection against ending on a ventilator. There's a hope now that with our updated bivalent boosters, which are now available, that for some appropriate period of time, based on timing, we're going to get some added protection, maybe some decrease in infection. We're certainly going to get a boost in those antibodies in individuals. But again, you don't want a patient to feel like the vaccine has failed when they get infected, because people certainly get infected after the vaccine. But as I always, ask my patients, but did you die? Did you end up on a ventilator? Did we keep you out of the hospital? So really important that we encourage vaccination. Who's dying? And it still shocks me. The majority of patients that ended up in the hospital are still the unvaccinated, even though they make up a minority of our high risk individuals. But what about those individuals who have been vaccinated, but for some reason are still at risk of a bad outcome? Either they're immunocompromised, or they for some reason are not able to tolerate the vaccine, or for some reason cannot get a response to the vaccine. So instead of hoping that they make those antibodies, which in some cases they can't, this is really an underutilized therapeutic. And this is the passive immunization. This is Evusheld, which I tell people, let's not turn this into Evushelf. And this is really impressive. This is actually data that we have, which is really compelling. And it's actually protection even against infection, a greater than 90% reduction in developing symptomatic COVID-19. This graph I sort of show, and you can see this incredible separation. This is now something still paid for by the government. It is now recommended every 6 months. We are seeing a 95% reduction in people even developing symptomatic COVID. And remember, we are giving this to high-risk individuals, immunocompromised, unable to develop their own antibody responses. And in addition to the prevention of symptomatic COVID, we're seeing reduction in the risk of progression to hospitalization, significant mortality benefit. So let's think about those 500 people dying a day. A number of them are unvaccinated. We need to address that. Those that are vaccinated tend to be older, compromised, multiple medical problems. Another big reduction if we start employing Evusheld in our high-risk qualifying patients. And we're going to be talking about even more things we can do. So remember, this is pre-exposure. You want to get in here before a person has been infected, before they're in that incubation period, because unfortunately, now we move into the incubation period. And this has unfortunately changed over time. Currently, a person is exposed. They may be in the process of moving forward to being infected, maybe moving forward to having a symptomatic case of COVID-19. Currently, we have no evidence-based therapeutics in this space. We used to be doing post-exposure monoclonal antibodies. We used to be using Regeneron, the Regeneron cocktail, the Eli Lilly cocktail. Those have been pulled off because we currently do not think they have efficacy against the currently circulating variants. Unfortunately, even after they were pulled off, even after they were deauthorized, even after we said they no longer worked, about 150,000 doses were still given out. But no, let's follow the science. Unfortunately, right now, this is an open space. What about jumping in with Paxlovid or something that we'll jump in with? We'll talk about later. In this space, that has not shown to be benefit. So currently in this incubation period, this is someone you're watching, someone you're waiting, seeing, do they actually end up developing COVID-19? And we'll move into what happens next. So we've now talked about the pre-exposure period. We've talked about this incubation period. And there is a range here. We say 2 to 14 days. It's still 2 to 14 days. But with current variants, there's been a shift to the left here. Starting with the ancestral strain, median about 7 days. And then we've moved down now to a median of only about 4 days from time of exposure until people test positive. But that's your median. There's a left shift, but there continues to be a tail where individuals are exposed, but they do not test positive until out to about day 14. Once you get past day 10, you're starting to get only down to a few percent that still will end up with a positive test after that. So again, we're seeing a front load in that incubation period. But now we're going to move into what really is going to be critical is, has our patient moved into the early viral upper respiratory non-hypoxic phase? This is the viral replication phase. This is the period of viral symptoms. This is really the time when we have the ability to make the biggest difference. As we'll see once we get into the second week, diminishing return. So we've already talked about a 90% reduction in progression to hospitalization and death with our vaccines. We've talked about adding Evusheld to our immunocompromised, to some of our more vulnerable folks. But what do we do at this point? Well, the biggest thing we need to do is we need to make the diagnosis. And the way we're going to be making that diagnosis is using our tests. So we still have our nucleic acid amplification tests, those PCRs and all the PCR equivalents, those isothermal point of care machines. This continues to be a very sensitive and specific way of making the diagnoses. But what we've really seen, and I think this is positive, is an expansion of acceptance and accessibility of our antigen tests. I'm going to go ahead and I'm going to suggest that these are just as sensitive and accurate for Omicron as they were for Delta and the other variants. But again, timing's going to matter when you do these tests. So a big change that we have seen over time is we are starting to see symptoms preceding the positive tests, and we're introducing the role of repeat testing, orthogonal testing, as the fancy word for that. Some suggested this is because of prior infection, because of vaccination. It's not clear that a person who is unvaccinated and having their first infection with the current variants does not follow the same pattern that the vaccinated and previous. So this looks like this is actually a feature of the current variants, is that people often have symptoms before they get that positive test. So this is the current recommendation. Person starts to have those symptoms that first day. If there's a reason to be concerned, which there is almost all the time, they wait that first day. The second day is when you're going to start testing the individual. If they have, so we'll say day 0 is the onset of symptoms. We'll make that a Sunday. Monday morning is when you want to do that test. First time in the morning is a great way to do it. If it's positive, then you can feel pretty confident. If it is negative on day 1 on Monday, then it is recommended that you actually repeat tests. You might repeat that test Tuesday, or the recommendation is Wednesday morning, 48 hours apart before you feel confident that this is something else. One of the important things is there can be something else. People can have more than one infection. People can have something other than COVID. I think we've come to realize that co-infections are a significant part of infections across the board. We realize that a lot of individuals with COVID may also have the flu. They may also have an enter or a rhinovirus. And then the reverse of that might be true as well. Just because you have influenza doesn't mean you don't also have COVID. So the flu-rona thing that is circulated, but really just making us appreciate you can't rule out COVID with a positive flu test. The way you rule out COVID is with a negative COVID test. And if a person has COVID and the flu, you may even be considering treating both. But I will say these are really viral co-infections. So we're going to be talking a little bit about how often do people actually have bacterial co-infections. How often should we be giving out the antibiotics? And as we're going to talk about a little bit, that's going to become not so often. So really important, first off, remember our oaths, do no harm. This first week, you want to avoid steroids. I'm going to talk a little bit about the data here, but giving someone with COVID steroids during that first week is going to increase their progression to hospitalization or death about 3-fold, maybe even more. So you really want to not give these people steroids at the wrong time. So where are we in the disease process? It's the first week. We want to avoid steroids. We'll go into the data on that. We also want to avoid unnecessary antibiotics, things like azithromycin, doxycycline. Big meta-analysis, big studies, only about 3 to 4% of people with COVID-19 end up with a bacterial infection during their entire course. So if we're giving out antibiotics more than about 3 or 4% of the time, we're not doing anything helpful. We're messing with the microbiome in someone who's already trying to fight off COVID. We're increasing antimicrobial resistant rates. We're giving drugs that might actually potentially have cardiac impacts to individuals with a disease with cardiac impacts. And the biggest thing we also have to start doing is let's stop recommending or prescribing unproven remedies. Don't just grab stuff off the shelf. Don't grab that zinc because all it's going to do is make your patients vomit and give them GI upset. Don't give them the ivermectin or the fluvoxamine. We've looked at that, not helpful. And there actually are lost opportunity costs. So let's follow the science here. But let's talk a little bit about when I say do no harm, why do I get so fired up about the steroids? So number of studies, we looked at timing given in that first week to patients who are not hypoxic, who just are in that early viral replication, early viral symptom phase, non-hypoxic phase. Overall progression to severe disease and hospitalization increased 6-fold in one study. In that same study, we saw mortality increase by 35% if given in the first week. We also saw in another study that given steroids was associated with a hospital admission adjusted odds ratio of 2.5. So 2.5 times as likely to end up in the hospital in this study, giving them steroids when they didn't need them, doubling of cardiac events, almost a tripling of their risk of ending up with a pulmonary embolism. And in this study, greater than a 3.4 adjusted odds ratio of dying if we give steroids in that first week. Steroids in the first week is bad news for folks with COVID. Let's not do this. I know some people think, oh, well, the cough is really bad. It will make them feel better. It'll make them feel better for a week, but it may end up pushing them in the wrong direction. They may end up in the hospital. They may end up dying. That will be potentially our fault. So let's not do that. What else do we not want to do? As I mentioned, we do not want to give antibiotics when they are unnecessary. There are a few, 3 to 4% of the time, when there's an associated bacterial infection. If you're giving antibiotics more often than that, you're overdoing it. There are multiple studies showing no benefit and potential harms. Doxycycline study, actually twice as many people died in the doxycycline group as the group that did not get doxycycline. Not statistically significant, but boy, doubling someone's chance of death, not great. Azithromycin, multiple studies, no meaningful benefit. Over 80%, in some studies, 90% of folks with COVID-19 have ended up getting antibiotics. So we really need to rein that in. That is not helpful, but what is? So we'll go to the recommended evidence-based therapies. I'm going to go through these one at a time, but this is the order as far as recommended, and we're going to go through what we can do. So Paxlovid's going to be number 1, remdesivir, early IV remdesivir, number 2, poorly operationalized, but evidence there that we'll discuss. Monoclonal antibodies, we still have bebtelovimab. We still have one, and we'll talk about that. And number 4, it's really 3 and 4, because monoclonal antibodies and molnupiravir are sort of grouped together. That's also going to be a potential way of preventing people from progressing to hospitalization and death. And we'll talk about the data. But first, what I think a lot of people have been talking a lot about is Paxlovid. So hopefully people are preparing those questions about Paxlovid rebound. Is it better to give this? Is it better not? Is 5 days enough? We'll talk about the science there, but let's start with what we know about Paxlovid. So Paxlovid, if given in the first 3 to 5 days, is going to give us almost a 90% reduction in progression to hospitalization and death. So let's start adding up. Let's start off with those individuals who are unvaccinated, where this data applies. But what about those individuals who are vaccinated? We now have data showing that these individuals get a benefit as well. It may not be 90%, it may be about 75%, but still 90% reduction with the vaccination, another 70, 80% reduction with early treatment in that first week, not making things worse with steroids, not making things worse with antibiotics. So Paxlovid is currently authorized, EUA, to be given to individuals in this first week. It is the number 1 recommended. There can be a little bit of a lift. This actually takes a little bit of time. You don't just check the box. One of the things you want to do is you want to know, is my patient at risk? If you're looking at a healthy 30-year-old with no medical problems and their risk of going to the hospital is 0, their risk of going to the hospital will remain at 0. Paxlovid is not going to provide benefit. Remember, the science here is that Paxlovid prevents progression to hospital, prevents progression to death. We do not know if it prevents long COVID. We do not think that it makes symptoms better significantly quicker. It's actually hard to tell from placebo group if there's a significant impact on symptoms. Everyone thinks there is. I'll tell you that. There's definitely a psychological perception that this makes you feel better quicker. But number 1, you want to look at the list of factors for progression to severe illness. And you probably want to do this with your patients. I'm encouraging patients to go and meet with their primary care providers. Do this ahead of time. Have a plan in place. Do you qualify for early intervention in that first week? If you do, what is the basis for that? The next, you want to find out, where's the product. We're getting a lot better. At this point, it's almost in all the pharmacies, so that's not quite as heavy a lift. The next, drug interactions, and we have some tools to help with that. If they're on the statin, you're going to be stopping that for a period of time. Some other drugs you're going to actually have to be making decisions about. There certainly are a number of drug interactions, and our patients who are higher risk with multiple medical problems, these are going to be the patients who have those multiple drugs, and you're going to be looking at those interactions. And sometimes you're not going to feel comfortable with doing the Paxlovid, and we'll move on to our other options. The next thing, and I think I'll mention, is renal function. You need to know their kidney function. You don't necessarily have to know it the moment you prescribe the medicine, but if you prescribe that medicine, you can go ahead and check kidney function. And then if you need to, and I'm going to kind of throw these numbers out, if kidney function is normal, they get a normal script. If the kidney function is below 60, GFR below 60, then you're going to actually drop down to a renal dose. If they have renal failure, less than 30, then you're going to want to look at alternative therapies. So you're going to need to know, are they at risk? Because those are the people that benefit. You're going to want to know, where can I get the product? You're going to want to know what their medicines are, and you're going to want to know their kidney function. But remember, this is significant. We have 500 people dying a day. We can drop that by another 80% by jumping in here, 80, 90%, depending if we're talking about an unvaccinated or vaccinated individual. So this does benefit people with vaccination. But what about rebound? Unfortunately, we've heard a lot about the COVID-19 rebound, and this is defined in many ways. Sometimes it's folks who had a positive test, got a negative test, now the antigen test is positive again. Does that bother me? Would that stop me from reducing a person's risk of ending up in hospital or dying by 80 to 90%? No, I would move forward with this. Some people, and we'll talk about this, have a viral symptom phase, they feel better, and now they move into week 2 where they have that hypoxic early pulmonary phase. That does not stop me from giving them Paxlovid, because even if they have that, we have an 80 to 90% reduction of them ending up in the hospital during that second week. So Paxlovid has gotten a lot of press. The FDA has asked Pfizer to study 5 versus 10 days. We're waiting for the science on that. 5 days is what's recommended. 5 days is what the science shows. Remember, think about what we're trying to do. We're trying to shut down the viral replication. That really is an issue during that first week. It's that first week the viral replication triggers that cytokine storm during that second week. So my advice, or the science, I would say, is let's not deprive our patients of a truly effective therapy just because of what's going around in the media. Look closely at the science. Now, as I mentioned here, remdesivir is number 2. Now, this changed, the order changed here a while back, but this is poorly operationalized. So unfortunately, when we have that patient for whom we don't want to do the Paxlovid, maybe it's an issue with a drug-drug interaction, maybe it's an issue with the renal function being too low. Ideally, the next step would be to offer them remdesivir. And what is the science here? Now, remdesivir is certainly a drug that was plagued with being used at the wrong time. If you use an antiviral after the viral replication is already on the way down, hopefully you wouldn't expect much benefit there, and we did not see that. But remdesivir, if given in the first 5 to 7 days, in the first week, a 3-day, 200 milligrams, and then 100, is associated with an 87% reduction in progression to hospitalization, severe disease, and death. So really a huge benefit here if given. Unfortunately, as we look out, a lot of healthcare systems have not really operationalized this because it is IV. You've got to go somewhere. You've got to go somewhere for 3 days, but 87% reduction. So really, really impressive intervention if our patients have access. All right. So monoclonal antibodies, and talk a little bit about this because monoclonals, molnupiravir, are sort of grouped together. Why are the monoclonals not way above molnupiravir? Well, let's talk about that. And part of it is a changing landscape. Early on, I will suggest that the Regeneron cocktail, the Eli Lilly cocktail, really had a major impact upon the number of people that were progressing to hospitalization, severe disease. We were looking at numbers in the mid-80s, not quite Paxlovid level. We probably were seeing a period of time after that infusion where they were continued to be protected against those early circulating variants. Data was really compelling. And then onto the scene came Omicron. Unfortunately, with the Omicron variants, with some of the changes in those, even though we thought maybe certain of our monoclonal antibodies would be variant proof, variant resistant, we really lost efficacy of those agents. And it dropped us down to the one last standing acute therapy monoclonal, which is bebtelovimab. Now, we do not have any efficacy data on bebtelovimab. We are hoping it works. We suspect it works. We have data from the lab showing that it should neutralize the current circulating variants. But without efficacy data, it's a bit of a challenge. One of the other challenges is that bebtelovimab is moving from being purchased by the government to now being purchased commercially. That has really bumped up the price tag. Now patients are expected to cover this. Some of our local healthcare systems, $12,000 if you show up and get your bebtelovimab. So something for us to be thinking about if we're moving down this far into the list. We're not sure about the efficacy. And also, we're moving from therapies that you can start right away. And I think that's another issue. Timing really matters. A lot of healthcare centers say, that's great. We'll take your name. We'll take your number. Fortunately, you're calling us on a Friday, so we'll try to get to you Monday or Tuesday of next week. Every day that we delay monoclonals, and we have data from the early monoclonals, we are losing efficacy. So that's why molnupiravir has moved right up to be on par to be thinking about with monoclonal antibodies. So molnupiravir, Thor's hammer. Let's talk a little bit about this. Early data, we were very excited, but by the time those initial studies that stood behind the EUA were published, we were only seeing about a 30% reduction in progression. There's certain benefits to molnupiravir, no renal issues, no drug-drug interactions. It's on the shelves, so it's something your patient can get on right away. So we're not going to have that delay. I'll also say that we do now have data, real world data in the unvaccinated, real world data in the vaccinated, showing reduction of progression to hospitalization or death, actually even a little bit more impressive than the early EUA suggested. But you want to be a little bit careful here. Women of childbearing age, we want to get that negative pregnancy test. We don't want them to get pregnant while they're on this therapy. It's also not authorized for those under the age of 18. So we're going to have a little bit of a impact here as far as who can use this. But I feel like this is an underutilized medicine. All right. So we're not quite to the pulmonary phase, which we're going to spend a little time on. But when that person comes in during that first week, a big thing that they keep asking us now is, after 5 days, am I fine? Can I go back out? Can I do these things? And so the CDC guidance, what is the science? And I want to sort of be focused here on the subtleties. This is not just a 5-day disease. The height of transmission, the most infections are transmitted 2 days before, 5 days after, but that doesn't define 100%. So there are rules, there are advice, there's guidance. Some people follow them, many people don't. After those first 5 days, a lot of folks need to get back to work. They need to get back to doing these other things. The CDC is saying you still may be infectious after day 5. And the recommendation, and we can have this conversation with our patients, is they should continue to wear a well-fitting mask around others at home and in the public for an additional 5 days. One of the changes here is a lot of discussion about, can I just do that rapid antigen test? Can I get out of isolation sooner? Maybe I need to stay in isolation longer. And so the CDC has actually introduced testing to isolation. So as they say, if an individual has access to a test and wants to test, the best approach is to use an antigen test toward the end of the 5-day isolation period. Really interesting. If you look through kind of the details here, you need to be fever-free for 24 hours without something keeping you fever-free. But how well does this work? What's the predictive value? And so I'm going to touch a little bit on this. Maybe there'll be some questions here. What if we go ahead and look at those tests? Here it is. It's day 6 or 7. You get that negative antigen test. You're feeling pretty good. 50% of those folks with a negative antigen test actually have a positive viral culture. You can flip it around and look at the other way. Well, what if you have a positive test on day 7 or so? Well, about 50% of those people don't have a positive viral culture. So I'm going to again suggest that timing is the most predictive in even cases of ending isolation. The first 5 days are the most contagious, and that drops and drops and drops. In the early studies out of Taiwan, we saw no transmission after day 70, and this is looking at thousands of individuals. There has been some shift, we think, with the current circulating variants, that the period of transmission of infectiousness may not be the same as the early ones. But I want to throw this out there because there's a lot of excitement about testing, but there's still a lot of uncertainty. And now, and I think this is really critical, the early inflammatory lower respiratory hypoxic phase. That's week 2. Folks get through week 1, particularly high-risk people. And this is when I say, all right, I'm not as worried about week 1. We do certainly see people during week 1 end up in the hospital. They feel crummy. They've got diarrhea. They're vomiting. They can't keep up with PO intake. They're frail, and this pushed them over the line. But it's week 2, which is really what drove a lot of the hospitalizations. This is the cytokine storm. This is when they start dropping their blood oxygen levels. This is when I want my patients monitoring their oxygen. This is where if I vaccinated them and given them early treatment, I've significantly reduced the risk that this is going to get severe enough that they'll require in the hospital. But remember, this is week 2. This is the second week when some people started to feel better and now they feel worse. We've been seeing that for 2 years. I joke with my patients who didn't get Paxlovid when they have symptoms during week 2. I say, oh, that's Paxlovid rebound. They say, but Dr. Griffin, I never took Paxlovid. I said, doesn't matter. We're all calling it Paxlovid rebound. And if we don't, I'm not going to get that media spot on CNN. So the important thing to think about during week 2 is what can we do? And I want to point out we're now at a time of diminishing returns. We're not talking about 90% reduction in progressing. We're talking about more modest benefits. And what are those modest benefits accomplished by doing? Now is when you can start thinking about steroids. Remember, first week, you are doing harm with steroids. You are increasing their risk of a bad outcome. But during this second week, when they start to get hypoxic, when they drop down below 94, WHO might be 93, 92, or 90, this is when steroids may have a mortality benefit, maybe a 30, 35% reduction, as opposed to a fold increase used at the wrong time. We may be able to accomplish more immunomodulation with our IL-6 receptor inhibitors, things like TOSI. This is also when we want to start talking about anticoagulation. We have different recommendations based upon whether they're in the ICU, whether they're on the floor, but all our recommendations have the caveat of look at your individual patient. Is this a 300-pound person laying there in bed, not moving around, or is this your 52-year-old person pacing back and forth as they finish off their remdesivir? So anticoagulation across the board, but we want to adjust dose based on risk factors, based upon severity of disease. Current recommendation, floor patients, the default is full dose. ICU is low dose because of the prophylactic dose because of increased bleeding. A lot of guidance on pulmonary support. This has come a long way. We're trying to keep folks off those ventilators. We're trying to use high flow nasal cannula, non-invasive ventilatory techniques. And we still have some benefit if given within the first 10 days of antiviral therapy with remdesivir. But remember, diminishing returns. Most of our benefit is if we can jump in early. Secondary symptom phase, and I think this is important. Some people have that, I felt worse during the first week, I felt worse again during the second week, but some folks will do fine for a while, and then about week 3 or 4 is when we start to see a either secondary symptom phase just because of a bimodal nature of the inflammatory process. But this may also be when we see secondary bacterial infection. So really the way we guide the secondary symptomatic phase is diagnosis guided therapeutics. What is going on? Why are they starting to feel bad here during week 3, 4? And then once we've looked, is it a bacterial? Is it inflammatory? Is it thrombotic? Then we want to base what we're going to do based upon that diagnosis. And then the tail phase. The tail phase is tough. We have millions of individuals who had acute COVID. It didn't just last 5 days. It didn't just last 14 days. It didn't just last 30 days. We have individuals now 60, 90, even individuals 2 years out who continue to suffer, who've actually gone on and developed the tail phase, what we refer to as long COVID or post-acute sequelae of COVID. what are we looking at in these individuals? We say fatigue, but it's not just I'm tired. This is debilitating fatigue. This is the inability to do their job. These are triathletes who have problems going up and down stairs. These are mothers who carry their child for several minutes and now they need to collapse. This is really a debilitating fatigue. There's a significant cognitive impairment that we see in a lot of individuals. This isn't just, oh, I'm just not thinking clearly. This is, I'm not thinking clearly. I can't do my job. I can't function. College professors who can't even sign their name on a check because they've lost the ability. Pilots who can't go back and fly planes. A number of pulmonary issues might be seen, cardiac issues, GI issues, insomnia, mental health, and the list goes on. One of the nice things I will say at this point is we're at least starting to get a sense that there are different types, there are different buckets in the tail or long COVID patients, and sometimes they can respond to certain things. So there is actually some optimism here. If it's new onset migraines, we can work with our neurologists. If it's cardiac issues, there actually are interventions that can be helpful. Mental health, really difficult to access, but really critical for these individuals. And sort of bringing it all together. All right. So hopefully people are realizing that timing matters. You want to get those vaccines active and passive. You want to do those behavioral modifications before you're exposed, putting that N95 on after you've sucked in a whole bunch of virus, getting that vaccine after you've already been infected. Not quite what we hope. So use those pre-exposure modalities. And then once you get into that first week, that's where we can make the biggest difference. Let's go ahead and do that. Let's not let some media conversations scare us away from what the science is showing us. And then we want to really watch our high risk people for that second week. That's when we start looking at immune modulation, anticoagulation. And unfortunately, we have a lot of folks out there with long COVID. But let's be positive. There's a lot of studies. We're learning more. We're moving forward. And some of our symptom-based therapeutics are actually helping these individuals. So if you want more information, we keep a website updated every week with articles that are worth reading. We also do a weekly clinical update. I try to keep people up to date. What's the latest literature? What have we learned? Because this has changed. It's changed over time. And if you're still treating the way you did 2 years ago, even the way you did a year ago, you're not giving your patients the level of care that we would like to see them get. So let's try to keep them updated. Also, welcome to shoot me emails. And hopefully now we'll enjoy some live Q&A.
Well, Dr. Griffin, I want to thank you for that informative presentation. And we are starting the live Q&A portion of this webinar. So I want to encourage our audience to go ahead and submit some questions now. Just click on that Ask a Question box located on the far left of your screen, and we'll get those questions that come in. And, you know, as we're waiting for these questions to come in, are there common questions, Dr. Griffin, that people have around this particular presentation that we can maybe zero in on as people are typing in their questions?
You know, the big takeaway that I hope people get is one is the vaccines are working. The vaccines are preventing, they're really giving a disconnect between infection and people dying. If people with a short memory, January of 2021, right after vaccines became available, before we really rolled them out, we were looking at over 3,000 deaths a day. And now we have more infections out there, but yet the deaths have dropped to 1/6 of that. And I think that's because our vaccines are really keeping people from ending up in the hospital. They're keeping people from dying of COVID, but you're going to get infected. And I think and then the second, hopefully people are going to really realize that we can do stuff now. So when that patient gets diagnosed, just don't tell them you're probably going to be okay. That might be true. But for those 500 people that die a day, if we had jumped in, we could really reduce that number. The majority, not all COVID deaths are preventable.
Yes, absolutely. And I see that we have a couple audience members writing in that they really appreciate your presentation. I don't see any questions coming in at this point, but I do want to say that any questions that are not submitted today, you can still ask those questions because our speaker will address those via your contact information you provided at the time of our registration. And Dr. Griffin, again, I want to thank you for your time today. We really appreciate it. And actually, there was one more question that just popped up, and I want to thank this audience member. This person says, what about children? What about children in regards to therapies and vaccines? It's a great question.
Yeah. So, as we
Oh,
know, children are at lower risk, but they're not at no risk. And unfortunately, we have had over 1,000 children die from COVID, right? And that's much more than we ever see, with flu, things like that. And about a third of the kids that ended up in the hospital, and there were thousands of kids in the hospital, were before this, for all apparent, completely healthy kids. So it is an issue for children. So we do have vaccines and we encourage them. I say across the board, it doesn't matter what age you are, getting a vaccine is always better than getting COVID. We worry about heart issues. Boy, a lot more heart issues with getting COVID than getting the vaccine. So number one is the vaccines. But some of these therapeutics, particularly remdesivir, is available all the way down to 28 days of age. So you want to have that conversation with the pediatrician. I'm not a huge fan of the government telling us who should get vaccinated, but talk to your pediatrician, have that conversation, decide what's right for you. Across the board, children are better off getting vaccinated than getting COVID. And there are therapies. Those therapies, again, are not for everyone, but if you have a child who has risk issues, then there are therapies that can be employed. And again, timing matters. If you've got a child who has risk factors, that first week, that's the time to jump in.
thank you so much. And it looks like we actually do have some more questions. I love it. Thank you to our audience. How much is the ancestral monovalent booster dose effective against BA4, BA5, BA2.75?
Yeah. So I think a big game changer was Omicron. Initially we had 2 doses of the ancestral vaccine, and we were doing pretty well, maintaining that 90% reduction in progression to death. But Omicron really made this a 3-dose series. But what we just saw, actually, just over the last week, is the introduction of the bivalent vaccines. And so the really comparison was, what if you get a shot of that original, the ancestral, versus the bivalent. The bivalents are going to give you about twice the antibody levels that you get with the ancestral, but that was really the difference that we saw between Pfizer and Moderna with the original vaccine. So we're optimistic that the new bivalents are going to give us a little bit of a higher antibody levels, but we don't know yet what that's going to translate into what we're really after with our vaccines, which is reduction in hospitalization, reduction in death. But what we did see is with 3 shots of those ancestral that we actually were getting broadening of our neutralizing. We're actually getting neutralizing antibodies against BA5, and we actually saw continued protection against death and progression to hospitalization, even with the BA4 and 5 from those original vaccines.
Thank you so much. Now, there's a lot of distrust toward the science community and CDC specifically, for example, anti-vaxxers. What do you think could be done to improve the trust toward the general public? I love this question.
Yeah. No, this is a great question. And I
Yes.
think we need to go back to the original paradigm. And let's talk about children again, because that's a great. If you have a question about what's right for your child, I don't think you should go onto the internet. I don't think you should wait for a press release. You should talk to your child's pediatrician, your child's family practice doctor, your child's provider. Have that conversation, find out about what's best for you. There's a lot of media out there, and I understand. But I think we should go back to that paradigm. Ask someone you can trust. I'm not sure you can trust that social media influencer. Really, if you don't trust your pediatrician, you got to get a new one. Find that pediatrician, find that family doc you trust, have those conversations, figure out what's right for you.
Great advice. And we have time for 1 or 2 more questions. What if avirulent in vaccines turns to virulent?
Yeah, so the nice thing actually about our vaccines, as opposed to, we'll say, the Chinese vaccines. I mean, the current vaccine technology, the mRNA vaccine technology, there's no virus in there. So there's no ability for those vaccines to actually give you the disease. It's the same true for Novavax. Some of our old approaches, and we're seeing a problem with this with the oral polio, which we're trying to move away from, is if you use a vaccine, which is really just a form of the virus that is made less virulent, there is always that possibility that it can revert back. And that child we saw in upstate New York getting that polio paralysis because of a vaccine strain. So there is a big advantage to the modern vaccine technology without that risk of avirulent turning into virulent.
Thank you so much. And we have time for one more question. This audience member says, I have a friend in her 30s who will not get the vaccine because she's terrified of her immune system setting off her eczema and psoriasis. Do you have any evidence-based research in regards to this? And I would just add to this for my own personal question, because is there a site for these kinds of issues where there are specific health concerns about, whether or not you should get the vaccine? Is there a place where people can go to see those things? Just to add on to that question.
Yeah, no. So this is a great question,
Yeah.
and this is not, again, something you want to be Googling and who tells me what. If you've got eczema, you probably have a physician that works with you that helps you with that. And the great thing to do is to have that conversation. Let them know your fears, your concerns. In general, your risk of having a flare and getting into trouble with COVID is higher than the risk with a vaccine. And we certainly are living at a point where most of us are saying it's just a question of when you've had COVID, when you're going to have COVID, how many times you're going to have COVID. And so really you're trying to choose between the lesser of two choices. Am I going to go ahead and get COVID without the protection and see what impact that has on the eczema? Or am I going to get a vaccine under controlled circumstances, coordinate with my physician if I have an eczema flare? So yeah, again, I keep sort of, echoing the same message. We need to get back to, if you've got a medical question, talk to your trusted care provider. Be careful of what you read out there on the internet, on social media. As we've learned lately, people are willing to say things that they know aren't true if it puts money in their pocket. So let's talk to people that we can trust, people who really are committed to taking care of us and giving us the best science-based advice.
Dr. Griffin, I want to thank you for your time today and your important research. And I want to thank our audience for joining us today and remind you that questions submitted today and during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand for 2 years until September 7th, 2024. And LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Be safe. Bye-bye.